Hi, what ultrasound images are necessary to prove tendon dysfunction in cases of a laceration injury? After an injury where the skin and underlying tissues are cut or torn, an ultrasound may be ordered to determine the extent of the damage. If the patient is unable to flex or extend the affected digit in the hand or foot, tendon dysfunction may be suspected. Taking the following images can help the examiner to conclude whether or not the tendon is still intact and what the degree of injury is. You want to start your exam at the site of the laceration to assess any damage to the skin layer and underlying tissues. There is usually a hypoechoic tissue seen at the site of the injury. You want to image the tendon from the myotendinous junction until the bony insertion to see which part of the tendon was impacted. Look for any loss of the fibrillar pattern. Sometimes bleeding from a torn tendon can be hard to recognize. Acutely, anechoic fluid may be visible within the tear, but over time the echogenicity increases, making it easy to mistake complex fluid for tendon fibers. You have to entirely sweep through the tendon in the long and the short axis to be able to visualize a break in the tendon in any segment and to determine the extent of injury. It's important to determine whether all of the tendon fibers are torn or only some of them. If there are some fibers intact, the tendon may still have some function. You should also use power Doppler to prove a tendon defect. There will be no hyperemia present at a site where there is a loss of tendon fibers. You also want to perform dynamic evaluation of the tendon during passive flexion to see if the tendon moves distal to the laceration site during joint flexion and extension. So once you've located the laceration site and you can see that there's no tendon fibers present or you suspect that, then you want to look distal to that during flexion to see if the tendon fibers move distal to the laceration site. If a disruption of the tendon fibers is present, more images should be obtained. When retraction is present, you want to locate the proximal and distal tendon stumps. Retracted tendon stumps typically appear hypoechoic and thicker than the normal segments of the tendon. So in this case, you could see where it was normal tendon, then it looked hypoechoic and thick right before you get to the spot where there's a loss of tendon fibers. You always want to label the surrounding structures at the site of the tendon rupture to provide as much information to the surgeon as possible. In this case, the bone was the most relevant landmark. So in the long axis images, you could see that the laceration occurred over the medial cuneiform bone, but after retraction, the defects extended from the navicular through the medial cuneiform and then all the way to the first metatarsal. And then you'll want to measure the distance between the two tendon stumps to provide the size of the defect. You should also use a dual screen to do a contralateral comparison between the torn tendon and the normal side at the exact same site to help the defect stand out to the image interpreter. This is an example of an extensor hallucis longus tendon laceration in the right foot. I really hope that this tip helped you to know which steps to take when you get a patient with a laceration injury. Thanks for watching.